Hi everyone, I'm Dr. Rebecca Jane Collins, and welcome. Today we're going to dive deep into what I think is one of the most challenging but also one of the most rewarding areas in our field, anesthetic management for ENT and head and neck surgery. We'll be covering the whole spectrum, from navigating incredibly complex anatomy and the shared airway all the way to fine-tuning delicate hemodynamics. My goal here is to give you a solid framework to help you walk into these cases feeling more prepared, more confident, and ready for anything.
But before we get started, I just want to say a huge thank you to all of you. Seriously, the work we do day in and day out, often under some pretty intense pressure, is just so incredibly important. As a practicing anesthesiologist myself, I get it. And that's why this session is designed by one of us, for all of us, focusing on the real-world, high-stakes decisions we're all facing every single day.
Okay, so we've got a packed agenda today, but I've broken it down into 6 main modules. We're going to kick things off with the absolute foundation, the anatomy of neck surgery. Then we'll get into the high-risk world of endoscopic and laser procedures and talk about some advanced airway strategies. From there, we'll tackle the big cases, major reconstructions, and touch on some specialized and oral procedures. And we'll wrap it all up with a real-world case study on a post-op bleed that I think you'll find really valuable. So let's jump right in.
All right, let's kick things off with Module 1, Foundational Anatomy. Now, I like to call this building the clinical map, because let's be honest, in head and neck surgery, anatomy is not just some textbook stuff we memorized for boards. It is our active, real-time roadmap for anticipating what could go wrong, preventing it from happening, and managing those neurological and hemodynamic curveballs when they come our way.
So, what makes the neck such a tricky neighborhood to work in? Well, it really boils down to these 3 things. First, you've got simple anatomical distortion. Look at that image on the left. A tumor can shove everything out of place so your landmarks are basically gone. Second, in the middle there you have direct tumor invasion, where the surgeon isn't just dissecting near vital structures, they're literally peeling a tumor off of them. And finally, on the right, you see the aftermath of prior treatments. Radiation can create this scarred, fibrotic landscape that turns a predictable surgery into a walk through a minefield.
Okay, this table is where the rubber really meets the road, connecting that pure anatomy to what we'll actually see in the PACU. Let's look at these critical branches of the vagus nerve. If the internal superior laryngeal nerve gets knocked out, the patient loses sensation above the vocal cords. The so what of that? Well, it means a huge risk of silent aspiration because they can't feel anything trickling down. Damage the external branch and you lose the cricothyroid muscle. The patient's voice becomes weak, breathy, and they can't hit high notes. And then, of course, the big one, the recurrent laryngeal nerve. This controls most of the muscles that move the cords. An injury here is what gives you that classic hoarseness, and in the worst cases can lead to a compromised airway.
And that brings us to the RLN injury, which is a tale of 2 completely different stories. Look at the left column. A unilateral injury is a problem, for sure. The patient's hoarse, but generally the airway is still patent. But now, look to the right. A bilateral injury is an absolute 5-alarm catastrophe. Both vocal cords become paralyzed in the midline, essentially slamming the door shut on the airway. This isn't a watch-and-wait situation, it's an immediate airway emergency that's going to need swift reintubation.
Okay, shifting gears a bit to hemodynamics. When the surgeons start dissecting around the carotid sheath, they can unleash a pretty terrifying autonomic storm. Any pressure on those carotid sinus baroreceptors can cause the bottom to fall out of the blood pressure, with profound bradycardia right behind it. Stimulation of the stellate ganglion can throw arrhythmias and prolong the QT interval. In the most dramatic cases, you can even see a sinus arrest. So what's our play? Well, it's all about communication. We need to be talking to the surgeon, and our go-to strategy is to have them infiltrate the carotid sheath with some local anesthetic. It's like cutting the wire on the alarm bell before it can ring, and it can work wonders to stabilize things.
So how do we protect these nerves? Well, our main tool is intraoperative neural monitoring, or IOMM. And the star of that show is the NIM endotracheal tube you see here. On the left is the tube itself with those little embedded electrodes, but the image on the right, that's the whole ballgame. Those electrodes have to be in direct, firm contact with the vocalis muscle. If they're not, that expensive piece of technology is basically just a very expensive standard ETT. It's doing nothing for you.
So it's really important to remember that using a NIM tube isn't just like swapping out a regular ETT. There are key differences. Sizing for one. You actually want to go with a slightly larger size than you might normally choose, because the goal isn't just getting through the cords, it's ensuring that solid electrode contact. And this one is a classic gotcha, the lubricant. You absolutely cannot use anything with local anesthetic in it like lidocaine jelly. It'll just numb the cords and poof, your signal is gone. And finally, placement is everything. That little blue band has to be sitting perfectly between the vocal cords for the whole system to work.
All right, on to Module 2. We are now stepping into what I consider one of the highest stakes environments we operate in, the shared airway, especially when there's a laser in the mix. In these cases, our job expands. We're not just managing the anesthetic, we are the primary guardians against an operating room fire.
Okay, if there is one number I want you to burn into your brain from this section, it's this one. The single most powerful lever we can pull to prevent an airway fire is the FiO2. The absolute cardinal rule is to keep it below 30% whenever you possibly can without compromising saturation. This is our number one, top-of-the-list defense mechanism.
It also helps to know the tools your surgeon is using. The two most common are the CO2 and the YAG lasers. Think of the CO2 laser like a super precise scalpel for the surface. It has a long wavelength that's absorbed by water, so it doesn't penetrate deeply. The YAG laser is more like a spotlight that goes deeper into the tissue, which makes it great for coagulation. But here's the bottom line. Both are incredibly powerful ignition sources.
This all comes back to the classic fire triad, right? But applied to our world. The laser is the ignition source. The fuel is our ETT, drapes, and even the patient's own tissue. The oxidizer, that's our domain. So our strategy has three parts. 1, control that oxidizer. Keep the FiO2 low. 2, and this is a big one, folks, it is non-negotiable. Nitrous oxide is an absolute no-go. It supports combustion just like oxygen. And 3, protect the fuel. Use a laser-resistant tube and fill that cuff with saline, not air. If the laser hits it, the saline will douse the fire.
So, which tube do we pick? Well, the tough reality, as this table shows, is that there's no magic fireproof tube. Your standard PVC tube, it's cheap, but it's basically a stick of solid rocket fuel. Red rubber and silicone are also highly combustible. Even the metal tubes, which seem like the obvious choice, have a downside. The shaft won't burn, but it can reflect the laser beam onto unprotected tissue, and its cuff is still flammable. The key takeaway here is that you have to be vigilant no matter what tube you're using.
Okay, worst case scenario, a fire happens. Your response needs to be immediate, automatic, and precise. There's no time to think. This protocol has to be muscle memory. Step 1, simultaneously stop ventilating and pull the tube out. You have to cut off the fuel and the oxygen at the same time. Step 2, kill all gas flow at the machine. Step 3, douse the fire. Get that burning tube into a basin of water. Step 4, re-establish the airway, mask ventilate, and get ready to re-intubate. Step 5 is critical. Assess the damage with a bronchoscopy. Okay, in Module 3, we're going to zoom out a little. For these really complex head and neck cases, our standard bedside airway predictors just don't cut it. It's time to move past that simple coin flip prediction of easy or difficult airway. We need to embrace a much more nuanced, multidimensional way of thinking about risk.
Just take a look at this view. Seriously, does a Malampati score tell you anything about that? Does a thyromental distance measurement prepare you for this kind of glottic tumor? Of course not. This is exactly why we have to be better. We need to become detectives, piecing together all the clues, the flexible scope report, the CT scan, the patient's symptoms, to build a complete 3D mental model of that airway before we even think about reaching for an induction drug.
You know, we focus so much on intubation, but in these complex cases, extubation can be the most dangerous part of the whole anesthetic, so we need a game plan. Sometimes, the smartest move is just to wait. If you have any concern about swelling, deferring extubation is never the wrong answer. For an extra layer of safety, you can place an airway exchange catheter before you pull the tube. It gives you a life-saving pathway back into the airway if things go south. Or, even better, extubate over a flexible scope so you can literally see that the airway is wide open. And for every single one of these cases, you and your team need to have a crystal clear plan for reintubation. You make the plan before the crisis, not in the middle of it.
All right, let's get into the marathon cases. Module 4, Major Head and Neck Reconstruction. We're talking about those long, complex free flap cases. And I've found that the key to success here is having a systematic approach, what I think of as a personal standard operating procedure for these anesthetics.
The success of a free flap comes down to one thing: keeping blood flowing through those teeny tiny freshly sewn vessels. To do that, we have to hit what I call the rheological sweet spot, and this table breaks it down. Think of it like a highway. If the hemocrit is too high, it's like having too many trucks on the road. You get a traffic jam, which is high viscosity and poor flow. Too low, and you're not delivering enough oxygen. So we aim for a sweet spot of about 27 to 30%.
We keep the blood pressure right at their baseline. We use vasopressors as little as possible, especially phenylephrine, which can really clamp down on that flap. We stay perfectly euvolemic with goal-directed fluid therapy. And we are absolutely militant about keeping the patient warm, because hypothermia is a flap killer.
Now, during these massive resections, surgeons are navigating a minefield of critical nerves, which you can see mapped out here. Preserving these is so important for the patient's future quality of life. And we have to remember that our anesthetic plan, specifically how and when we use neuromuscular blockers, has a direct impact on the surgeon's ability to find and protect these nerves.
I find it helpful to think of these long cases as a three-act play, where our anesthetic priorities completely shift from one act to the next. In Act 1, the pre-anastomosis or resection phase, it's all about stability and giving the surgeon good operating conditions, maybe with some controlled hypotension. In Act 2, during the microvascular anastomosis itself, our goals change. We back off the muscle relaxants so they can test nerves, and we need rock-solid blood pressure control for that delicate repair. Then, in Act 3, after the anastomosis is done, our entire focus shifts to one thing: flap perfusion. Blood pressure comes up to baseline, we double-check that we're in our rheological sweet spot, and we do everything in our power to avoid vasoconstriction.
Okay, let's move on to Module 5 for a quick hitter on some other common procedures. We're just going to cover a few key anesthetic pearls for ear and oral surgeries because they each have their own unique set of challenges.
Let's start with ear surgery. Rule number 1 for a tympanoplasty: turn off the nitrous oxide well before the surgeon places that graft. It can diffuse into the middle ear and pop it right off. You'll also need to be prepared to limit muscle relaxants for facial nerve monitoring and get ready to treat some serious post-op nausea and vomiting. Now, for oral and nasal cases, it's all about managing bleeding in a shared airway. Controlled hypotension is your friend, and you have to be super vigilant about aspiration, which is why there's almost always a throat pack involved. In these cases, constant, clear communication with your surgeon isn't just nice, it's a requirement for safety.
Okay, let's put it all together. For our final module, we're jumping into a real-world, heart-pounding emergency scenario. This is where all the planning and knowledge we've been talking about gets put to the test in real time.
So, picture this. You're in the PICU. Your 55-year-old patient from that sinus surgery seems to be doing great. He's waking up nicely. Then, all of a sudden, he has this violent fit of coughing and then spits up a frightening amount of bright red blood. Your PICU nurse is on the phone, and their voice is tense.
So you're hustling over to the bedside, and your brain is already firing off a differential, right? Number 1 on the list has to be a surgical bleed, maybe an ethmoid artery let go. But you can't completely rule out other things, like a pulmonary source. Still, Occam's razor applies here. The most likely cause is bleeding from the surgical site, and you have to act on that assumption immediately.
Okay, you're there? What's the plan? First things first, you're not a hero. Call for help. Get the surgeon in that room now. While you're doing that, you're getting vitals, making sure you have at least 2 big IVs, and sending a type and cross. You know this patient is probably heading back to the OR. For induction, this is a textbook RSI scenario, but it's an RSI into an airway that's full of blood. That means you need backup plans and, most importantly, suction. And I mean have that big, rigid Yankauer suction in your hand, ready to go, before you push a single drug. And choose your induction agent wisely. Something hemodynamically stable like ketamine or etomidate is probably your best bet.
Phew, okay. You and the team have pulled it off. The patient's back in the OR, re-intubated, the surgeon has gotten control of the bleeding, and he's stable. But you're not done yet. The last and maybe one of the most critical questions remains. What is your extubation strategy now? After a massive bleed, a traumatic re-intubation, you know that airway is going to be swollen and angry. This is the ultimate test of our judgment and brings us right back to everything we've talked about today. Do you use an airway exchange catheter? Do you leave the patient intubated overnight? It's the perfect reminder that for us, the case isn't over when the drapes come down. It's over when that patient is safe, stable, and breathing on their own. Thanks so much for joining me today.